We're going to have the first of our three case panel discussions. This one is on myeloid malignancies. So we're going to reprise the speakers. So we're going to actually touch on three cases. We're going to ask you what to do. I suspect our speakers are going to ask their co-panelists what to do. And this gives us an opportunity also to delve into some areas that we weren't able to cover in the didactic talks. So no rest for the weary. Jessica, you get to come back to discuss case one.
So if you haven't heard enough of my voice, we will talk about case one. So this is JW. He's a 76-year-old gentleman with an extensive medical history, I think pretty similar to what we see in our general practice often. He was diagnosed in 2011 with prostate cancer, was continued on active surveillance. In February of 2012, he developed diffuse large B-cell lymphoma, EBV positive, was stage 3A and was treated with 6 cycles of R-CHOP. He required a dose reduction and the cyclophosphamide and doxorubicin in cycles 5 and 6 due to grade 4 neutropenia. His course was complicated by C. diff colitis and a non-ST segment elevation MI. And then in August 2012, he was diagnosed with adenocarcinoma of his right colon, was treated with a right hemicolectomy, was MSI high, and didn't receive chemotherapy for what was stage 2 disease. Over this last year, he developed progressive cytopenias, and he was referred to CS with a white blood cell count of 3.0, hemoglobin of 10.3, and platelet count of 31,000. So, what's the diagnosis? Looks like everyone knows what talk they're attending, or at least 71% know. So I don't know, Ruben, is there something else this could be than therapy-related myeloid neoplasm?
Well, I mean, certainly that seems suspicious with all that level of chemotherapy that the person's had. I mean, it's certainly, they've had 2 distinct malignancies. So I think really nothing is off the table. I mean, it certainly could be clearly another hematologic neoplasm. I've had patients with very unexpected predispositions to cancer show up with hairy cell disease, or could this be a hidden plasma cell disorder? Or I think I wouldn't take anything off the table to start with, given they've had 2 distinct types of malignancies in a fairly short order.
Okay, so the evaluation to work on this would be what? Jerry, what would you start with in an individual that you suspect a therapy-related myeloid neoplasm?
For a workup?
Mm-hmm.
I'm going to be basically taking their marrow, sending it to flow, sending it to our rather broad panel of molecular diagnostics.
Great.
To go from there. Okay.
So this gentleman undergoes a bone marrow biopsy. He is diagnosed with acute myeloid leukemia. He has dysplasia in a very hypercellular bone marrow. His flow cytometry studies reveal a population that's DIM CD33 positive, CD34 positive, 117 positive, and partial CD7, and negative for all other lymphoid and monocytic markers. What items do you consider important in determination of prognosis and treatment plan? Great, thank you. So the vast majority of you thought that disease-related characteristics, the cytogenetic and molecular features, and patient-related characteristics, patient's comorbidities and his performance status were all important. Do you guys have anything else you would like to add as you're thinking about prognosis in an older patient with newly diagnosed therapy-related myeloid neoplasm?
Well, I mean, a gentleman who's with the secondary AML, obviously the risk is going to be much higher. The chance he's going to respond to anything is going to be about half of what it would be if it was de novo. And so, you have to take that into account. But really, this is what it stacks up to. If you basically see what the molecular features are, and then that will give you some idea of what the options are, but then your hand's going to be forced really by, what they are physiologically, and that's not age as much as just what their real performance status is. I think most people now have gotten away from age as being the main thing. It's just basically, what performance status is, and by whatever measure you prefer.
Yeah, I would certainly agree, and certainly I think given that history, particularly the two separate malignancies, I'd say that there's no way I would ever convince myself that this is not incredibly high risk. But also that the likelihood of success, is likely going to be less. So it's certainly mindful of that as to, where along the way an end-of-life discussion is appropriate in somebody who's kind of facing their third strike and probably the most serious of the 3 strikes.
So yes, we were very concerned about his both abilities to withstand treatment and his response to treatment. And some additional data kind of came in. He had a karyotype with a ring chromosome 7, a second clone as well. And his molecular studies were a bit piecemeal between his outside center and what my colleague was able to do. And more extensive molecular profiling was not completed other than the NCCN required or recommended molecular studies in addition to an IDH. In terms of his organ function, as we were thinking about what treatments to offer him, he had a normal creatinine, normal DIC panel, liver function was normal with a preserved albumin and uric acid. His performance status was 2, though he looked on the more robust side of 2. His albumin was preserved. Next question that I have for you is, what treatment would you recommend? So I'll summarize. This is a gentleman in his mid-70s with a therapy-related myeloid neoplasm with the cytogenetic abnormalities that you saw, preserved organ function, and a complicated medical history. Great. So I don't think that there is a right or wrong choice of these. I specifically did not design a question where there is a right or wrong answer, because certainly this is what we are confronted with. I don't know, Jerry, can you tell me why you would choose one of these options?
Well, I mean, I think that without ever seeing the patient and kind of smelling how they are, the choices at our institution would usually be between a 7 and 3 approach if they looked really physiologically better than this one did, or choice number 4. Clofarabine, I got to tell you, I've had, with older people, I've had a lot of people who look good on paper who get that drug and just fall apart, especially their renal function. And so I've been very impressed at how toxic that is in people that I'm shocked that it's as toxic to. So I really am kind of worried on that. And I think that, of those, 5-AZA is probably going to be the least toxic. And I think it's, in some patients like this, it's reasonable to try and see how they respond, and even if it's too toxic for them, that's one thing. And if they seem to be getting a response and stable, then that may be what you get.
I agree. I will share some data, comparative data of clofarabine in a moment compared to 7 and 3 in older adults fit for chemotherapy. So we'll have a chance to talk about that. Jerry didn't mention the role of best supportive care alone. Certainly we would think of all of these options as combining best supportive care in addition to the treatment. But potentially one option is offering this gentleman best supportive care, seeing how his counts go over a period of time and not committing him to treatment that requires him to come to either downtown or to his local office multiple days or every day a week, and then time period off. So best supportive care is also an option.
It's always an option.
So some thoughts as I'm reflecting about treating the older adult with intensive chemotherapy. So one who is potentially that you would consider fit for intensive chemotherapy. As we approach older adults with newly diagnosed acute myeloid leukemia, the 2-year survival is between 15 and 20%. There was data from the Swedish Acute Leukemia Registry in an unselected cohort. So all of the adults with newly diagnosed AML in Sweden were looked at in this registry data. 55% of the patients 70 to 79 had intensive chemotherapy, including 44% of those 75 to 79. I think that's a lot higher than we would think we would see in the United States. Half of those treated actually achieved a complete remission. So I think that's one piece of very interesting information as we think about treating folks moving forward. We would like really great risk algorithms. I would love to be able to have either an app or even a kind of an old school piece of paper to be able to come up with an algorithm as I assess my patients with acute myeloid leukemia. But there are limitations of all of the available algorithms, and none are really widely accepted. So patients with some disease characteristics we know are really unlikely to benefit from intensive chemotherapy, even if they're fit and they're really asking for intensive chemotherapy. And therefore, I would rather offer those a less intensive approach and certainly an investigational approach if that's available. Those folks are considered overexpression of EVI1 or inversion 3, ASXL1 gene mutations, FLT3 ITDs, and P53 mutations. In addition, those with the complex or monosomal karyotypes, we know that the disease biology is really bad. And for those, I would only consider intensive chemotherapy if I thought a stem cell transplant was realistic.
So one of the things to bring up here is I believe this person had monosomal karyotype, which is pretty bleak. The other thing that I didn't see a P53 analysis done, but the group out of St. Louis has something coming out which they showed a remarkable response, at least in achieving complete remissions, to a 10-day course of decitabine.
Correct.
It's like 80% or so, which is, I don't know if that's really going to keep up, but it seemed like too good to be true. But that's going to be out there.
Yeah, so what Dr. Radich is saying is the presence of a DNMT3A mutation appears to have an increased sensitivity to hypomethylating agents. This was first looked at by Bill Blum in the Ohio State group, and the data is kind of being expanded upon. I think that's what you're referring to, right?
Yeah.
Okay.
The other thing I'd add about these older folks, and perhaps my perspective is primarily in individuals that have progression from a chronic myeloid disorder, given my practice, but the variability really before they kind of become sick. And this individual, if they're really sent to you because of the cytopenias, they didn't really present with being sick. And it's always that window, in a non-curative setting, how long is it really going to be before they're really going to have an impact of that AML? Right. Is that 2 months? Is that 6 months? Is that a year? Because I've seen, remarkably variable courses that can be really, really benign, and then they kind of fall off the cliff. But it's kind of acute, and that might be for the best. Yeah. Versus those that are really have kind of hyperproliferative type AML from the beginning. They've got a ton of blasts. You've got to be cytoreducing them. So certainly a case could be made for someone like this for kind of close watching. Because they might have been like this, forever. Could be like this for months before they really, push your hand.
We got an inkling, right, of this gentleman's inabilities, we got an inkling of his bone marrow dysfunction maybe when he was requiring dose reductions of his chemotherapy with the treatment of his diffuse large B-cell lymphoma. So certainly we kind of refer to this as kind of a smoldering AML. These folks exist, and it tends to be seen in the more older patient population. So I'll get back to the data with clofuribine. That was one of the choices. The Eastern Cooperative Oncology Group conducted a randomized phase 3 study with the data presented at this past year's ASH, looking at older adults who are fit for chemotherapy, 60 and older, comparing 7 and 3 in the red line to clofuribine. And this was a very restricted inclusion criteria. The creatinine needed to be in the normal range. Secondary, as you heard Jerry mention, he was very concerned about the renal dysfunction that can occur with clofuribine. And the hope on this trial was that clofuribine would be better. It was also powered that clofuribine would be accepted if it was as good as 7 and 3. Unfortunately, neither of those were the case. So we're frequently confronted with someone that you could look at one way and you think they're fit for chemotherapy, and then you look at them the other day, or you put them in the hospital for a couple days and you think they're not fit for chemotherapy. And how do we make this decision of standard chemotherapy versus a hypomethylating agent, 5-azacitidine or decitabine? So there was a large randomized phase 3 study that looked at individuals 65 and older, comparing them to receive conventional care treatment, which included standard induction chemotherapy, low-dose ARC, or best supportive care alone. And they were randomized to receive that or one-to-one randomization to azacitidine. And while the conventional care was a hodgepodge of things, it's kind of very real to real life. And the median overall survival was increased with the 5-azacitidine arm of 10.4 months compared to 6.5 months. And there was an improved 1-year survival rate as well. Inklings from this data and from Behar data as well, that particular AML genotypes, as Jerry mentioned, the DNMT3A mutation and also the TET2 mutations may benefit particularly from hypomethylating agents. So back to John. He was treated on the phase 1b trial of the hypomethylating agent plus venetoclax. He entered a CRI after 1 cycle and then a full complete remission after 2 cycles, and this has now been maintained over 6 months. And this is a schema, I think you all should probably have this in your handouts or available in your app. And this is a general approach to the treatment of an older adult with acute myeloid leukemia. Essentially, the goal to think about both the patient characteristics, the disease characteristics, their social assessment, and I can't stress enough the importance of well-designed clinical trials, but I fully understand that there's not always a trial available, and it's not always feasible. So I'd like to turn to my other panelists.
I think you're fine. I want that sign Andy has. It says stop.
So Dr. Radich, case number 2.
That was great.
So here we have a case from the Great Northwest. This is a 45-year-old rodeo clown who presented with fatigue and easy bruising. Like, well, how would you know, right? But basically, the long and short is, when you look at all of this, is this gentleman has high white count. He's got 2% blasts and basophils in his peripheral blood. He's got a hypercellular marrow with only 2% blasts. Cytogenetics, which are typical. B-cell is 92. He's got CML chronic phase, and he's an intermediate risk SOCAL. Won't make you go through that exercise. So here's what you do. You decided you're going to start him on imatinib. And at the 3-month mark, he says he's tolerating it okay, but your pharmacist tells you that he really hasn't been doing very well in filling his scripts, so you wonder about that. He is a rodeo client after all. He's 3 months, his PCR is 30%, which is not the milestone. The milestone for the NCN guidelines are 10%. So as we talked about, that puts him at a little bit higher risk of bad things happening in the future. So what would you do? Do you change the second generation? Do you keep him on 100? Do you go to a transplant, or always talk to a transplanter? Or keep him on 400 if you really think that adherence has been optimal and just scold him? Or increase to 80 milligrams or 800 milligrams a day of imatinib? Yeah. Okay, so I think this is a pretty good choice. I'm a transplanter, but I think number 3 was absolutely I wouldn't do. And you can make again, the 3 months versus 6 months, a hard call. But if you talk to people, there are certain docs out there in the academics who basically say never change anyone at 3 months, just to wait till 6 months. But then if you actually confront them and say, okay, let's say that this is like in the old TB days, and the patient comes to your office and you dutifully put the pill in their mouth. And then they go, and they still haven't responded. And they say, well, sure, in that case, I would definitely change them, right? So how about you folks? Do you guys use these cutoffs, 10%, 3% at these time points? Does that make any sense to you guys?
I think it's a very helpful construct. I do tend to agree with you. We kind of look at 3 and 6. Is it really, from my end, is it really 3 months of truly taking the pill each and every day? Was that first 3 months with intermittent compliance, either because of any sort of shenanigans, or because of lack of tolerability? I was only taking one every 3rd day because I didn't feel well. So I think I certainly want them to have an actual real trial before trying to jump ship too quickly.
I agree completely. Though if the patient is not adherent because they're not tolerating the drug, I will talk to them about switching for that indication as well. Though in this case, I also chose 4.
That's perfect. So another editorial comment I feel like I have to make is that in medicine we're very good at changing rich continual variables into categorical variables, right? So this 10% is just not completely made up, but it's arbitrary. And someone who goes from 100% to 11% is very different from someone who goes to 100% to 80%, right? So even though there's a strict cutoff, you have to kind of use your common sense. It's like MDS and AML, 19% versus 20%. Come on, that's stupid. There's no biology into that at all, right? Or 5% versus 6% in your bone marrow and making a decision, that's ridiculous. But so you have to kind of use your brain to go forward. So I think that addresses that well enough. And here was just the data again showing that in 2 different studies, that the 10% versus less than that are as different. This is MD Anderson, this is London. So just a reminder, poor molecular response can be from adherence, it can be from bad biology, it can be often a mix. I don't know, I can kind of in the lab figure out this. I cannot figure out how to figure out predictors of poor adherence. I used to think it was a number of cats people might have, but then my last time I was on a transplant service, I actually had a put together person who actually had 85 cats at home. So that kind of theory got blown away. Didn't have toxo, amazingly enough. But one thing I think that you have to remember, and I make this mistake all the time, but I think we have to remember this, is the patient does not fail therapy. We always talk about that, this patient failed therapy. Patients don't fail therapy, the therapy fails them. Remember that. So we decided to continue, and at 6 months, the BCR-ABL is still above 10%, it's 14% now. And you do a mutation test because in the guidelines it says if you don't hit your milestones, you should do mutation testing. and you decide, because you like to do bone marrows, I don't do these anymore, but this person did, that they looked and did a marrow and found that they still have Philadelphia positive, which you would completely predict by that level, but there was no evidence of progression to accelerated phase of blast crisis.
Dr. Radich, I have a question before you go on. What amount of BCR-ABL do you need to have present in the peripheral blood to be able to successfully do a mutational analysis?
Okay, so the question is, how well does the peripheral blood BCR-ABL correlate with cytogenetics? It correlates pretty well. If you're at 1% or below, you will be negative in the bone marrow. Usually, there's outliers, but that's the usual if you look at tons of people.
I'm sorry, that wasn't precisely my question.
All right.
How much transcript do you need to have present to be able to successfully do a mutational analysis?
Oh, yes. So how much BCR-ABL do you have to have present? Typically, it depends on how you do the assay, but most labs can pick up a mutation in the ABL tyrosine domain if it's above 0.1.
Okay.
Typically. Your mileage may vary, but that's usually what we say. So this, again, is just showing the ELN and the NCNN. They have guidelines. I'm actually on both of these committees. I'm an honorary European because they basically need an American there for comic relief to make fun of our healthcare system. But the guidelines say different words, but they're really the same thing. Basically, if you don't hit your thresholds, or if you reach your thresholds and then relapse back out, you do mutation testing. And this is just, again, from the Hammersmith group showing that before they had tyrosine kinases, or other secondary tyrosine kinases, if you got a mutation on imatinib, your outcome was very bad. And that's because we and others have shown that patients who are getting mutations are sort of on the progression pipeline, and they have a much higher degree of going into accelerated phase of blast crisis. So these are people who were just randomly detected in this, and you make a landmark analysis at 24 months. These are people who don't have mutations, and these people who do have mutations. Obviously, you want to be on that curve. So mutations are serious. Now, when you get a mutation, you can go to these type of little heat maps, and what they are is they're completely artificial constructions. What people have done is taken a cell line, put BCR-ABL in it, sprinkled their tyrosine kinases and seen what concentration inhibits half the cells. And then they put in mutant clones and do the same thing and just see, well, which mutations affect the IC50. And you can sort of get a heat map. So for instance, for the E255V, you'd be okay here with the dasatinib. You obviously wouldn't want to give nilotinib or imatinib. And the one that works on none of these is the T315 mutation, which is what we'll talk about in a little while. So these, all things being equal, these can help guide you pick one tyrosine kinase over the rest. Although you always have a case where you've put someone on a secondary drug because you're not mutation testing back yet. Mutation testing gets lost. People have a fantastic response, and you find out they had a mutation where they shouldn't have, and vice versa. You'll see this person has this mutation, I'm going to this drug, and they don't respond. So there's clearly more to it than just the mutation. But this just shows that there is some correlation. This looks at the IC50 in chronic phase and determines whether they have no mutation or would be predicted to be sensitive versus those that would be predicted to be resistant. And in accelerated phase, it doesn't matter what mutation you have and what the IC50 is, you're going to do poorly. So we're ready to go to the next question. So they've failed 3 months, they failed 6 months. Now what do? You just be stubborn and hold the line. Do you increase the imatinib? Do you change to some other secondary tyrosine kinase? Do you go to transplant, or do you change to ponatinib? Suspense is killing me. Okay, everyone, I think that's the correct response. Anything you folks would do any different?
So in terms of the compliance issue, because I've been mindful that I've had situations like this, either one, it's hidden issues of toxicity, which I think question 3 is a correct response clearly, or is it 2 really a financial driver, of which the switch is not going to fix it? So did you have a sense, were they actually taking it, or not?
This is for someone who basically spends most of their CML life seeing other cases come in. This is the hardest thing to deal with, is that because there are so many second-generation drugs out there, so many switches, that the switch in people's minds about when to give up on toxicity and try something else is very small. And so you'll get people who've cycled through all these drugs, and they've come through and they've used like 4 different drugs, and you never get an idea whether they've ever gotten a fair shake in getting exposure to the drug or not. And so you're stuck with, is this person who's refractory to everything, or is this someone who basically every time anything came up, they pulled the plug, started a new drug, and you have no idea about how they're responsive. So that's a real problem.
I mean, I think this is a huge factor because, you know, the patients come in and I failed imatinib, I had a little edema. You know, I had, you know, a little rash with nilotinib. I had a little this, you know, and they're being sent to you to then have a transplant consult. You know, so we have a volunteer patient that has significant GVH, you know, who is volunteered to kind of visit with folks to kind of scare them, you know, into, you know, what is it like potentially to go through an allo transplant, you know, because if you didn't tolerate those drugs, you're going to hate having an allo. So to try to scare them back into light a little bit and again, try to resurface, you know, try to take that detailed history of those 4, you know, is it really worth going back to one of those? You know, rather than jump to an allo because of really compliance.
Right. Because then you're really talking. Anything else, Jack? And we'll get you on the next question. So we changed nilotinib, and that's well tolerated to begin with. And at 12 months, they hit a 1% milestone, which is what we want in the NCCN guidelines. So all is well. Now, one of the things you have to remember is if they really do fail because of resistance, you will get some of these people in a complete cytogenetic remission, but not that many of them. If you see those charts, these are all people who have failed first-line therapy, and these are the drug trials for those cases, anywhere from only 20% of bosutinib to a complete cytogenetic remission to 40 to 50% for the other drugs. So there would be a lucky few that you'll be in a complete remission, but you really shouldn't think that you're going to cure these people once they become resistant on the first go. And so the question then is, well, then how long do you treat them before you decide to declare it a victory or not? And so this is showing just one study out of MD Anderson. There's another out of Hammersmith that shows almost exactly the same thing, that if the person becomes resistant on imatinib and you put them on a second-line drug, you should wait about 3 to 4 months. And if you don't see a dramatic response by then, they're not going to. Now that works out perfectly because, you know, in the United States, not too many people have HLA family members, and so the average time for an unrelated donor search to come through is about 3 to 4 months. So at least in our institution, once we switch drugs, we have a transplant consult, we start an unrelated donor search. When they tell us that a donor is available, we go back and assess them, and if they have a tremendous response, we say, well, keep going. If they haven't, we pull the plug on the transplant then, because, as we'll show later, the more you wait and delay the transplant, if someone is really becoming resistant, the more likely you are that you're going to be transplanted in an accelerated phase of blast crisis. I mean, that's our life. So this person, we waited, and darn if they didn't indeed pop back up and start relapsing again, and we find a 359 mutation this time. Now, one thing you have to realize is when people become resistant, what you're playing is a game of Darwinian selection. That there are probably multiple clones once they become resistant, and all you're doing is basically adding a new selective pressure for different clones to come out. Here's one example of how this is shown. These baseline mutations, these are patients who went off of imatinib because they became resistant, and they either had wild type or a mutation before they got second-line therapy. So they get second-line therapy here, and then they again become resistant or they progress. So 12 of these people were in this thing. They basically stayed with their mutations. These are people who are relapsing for tyrosine kinase independent means, right, because they don't have a mutation. But the baseline mutations, 14 of 27 have the same mutation, but 13 have a brand new mutation. So these presumably are clones that are already there that you're just selecting out with selective pressure. Now, unfortunately, and this gets to one of the discussions that we had before about the use of markers in AML for minimal residual disease testing, our ability to look for baseline mutations or mutations throughout is somewhat limited by our technology. So we usually say for Sanger sequencing, you need about 10% of the disease to be present to reliably do an ABL mutation. For next generation sequencing, as fancy as expensive it is, you only increase the sensitivity by about 10-fold. And the reason is when you make, this is kind of in the weeds, but when you make libraries for next generation sequencing, you basically are making all the libraries off of one of the strands, and there's an error rate in the polymerase as you make these copies, and the error rate's roughly 1 in 1,000. So your theoretical limit that you can ever get is 1 in 1,000, right? Now there's ways around this, and this just shows an example of a new technique that a lab has devised for this disease and now for others. This is basically called duplex sequencing. So you actually take both strands, and you sequence libraries of both strands, and you only make a mutation call where the identical mutation is in both strands. Right? So if you have a random 1 in 1,000 chance of an error on one strand, you would have to get the exact same random error on the other strand to make a call, right? So here's an example. Here's up above is an ABL domain sequenced with next generation sequencing. And you can see they make calls from 0.5% all the way from some hotspots to 2 or 3%. If you do the duplex sequencing, you get no noise except for the one mutation. So you can, the theoretical boundaries of this is down to detection of one allele in a million. And they're developing panels to do this now for all the AML mutations. So pretty soon, I would suspect within a couple of years, we'll be able to broadly go through and do very, very high sensitivity mutations for all the AML markers and use that for minimal residual disease. Here's just an example of clones with therapy. These are 4 different mutations of some clones going up with tyrosine kinase therapy and some clones disappearing and some going up and then going down. And so this is the kind of the competitive network, the natural selective pressure that's happening with therapy. So next question. Now what do you do? This person's got a 359 mutation. Do you change to ponatinib, change to bosutinib, do a transplant, or change to omaxitaxine, henceforth Homo Harrington? And for order of time, I think I'll go through this pretty quickly. So ponatinib versus transplant, I think that's actually a pretty fair deal, is that ponatinib will put people in a complete cytogenetic remission for roughly about 70% of the time with a 359 mutation. They'll have a pretty good overall survival. We don't know how long it'll go out now, but most of them will eventually relapse, and you're facing the toxicity of long-term therapy, which is potentially substantial. So I don't know about you folks, but I would see this patient who's 42 years old, I would see using ponatinib, but I would use it as a bridge to transplant. I would basically start them on that drug, and as soon as I found a donor, I would head for the transplant option.
I would tend to agree. I think someone who's that young, the likelihood of really controlling them lifelong is really, greatly diminished. I think certainly their outcome with transplant is likely to be better if they're having a great response to ponatinib. So I think if there's a great response when the transplant should occur, I think would be, clearly a discussion.
I agree. I think that the patient's long-term benefit of transplant is likely limited, and also increasing numbers of years and exposure to ponatinib. I worry about the cardiovascular risks as well. But Ruben brings up a great point. It is not clear when best to transplant, right? We would like to get them to optimal response and before they lose their response, and we don't really know when that is.
And I'd say perhaps before month 24.
Yes, yeah. So this person was started on imatinib and kind of drugged their feet on the transplant, and they were one of the people who actually don't respond well. Now you're kind of facing the struggle of. So now what do? Do you start HLA typing now and search for a donor? I would wag a finger at you if that's your choice, because you should have done this a long time ago. Change to bosutinib, transplant, if you already did the HLA typing, or to omaxitaxine. And we have some non-Seattleites, but for the majority would like to do a transplant, which I think is the right thing to do. This is, again, just to show you the survival once people go into accelerated phase of blast crisis is rather dim. And this shows that survival is actually pretty good. These are going back, actually back more than 15 years for transplant. And this just shows that the top curve, you should basically be, for chronic phase disease, be hitting 80% survival. But if you wait till blast crisis, you go down here. Now, curiously enough, all the inroads that have made in transplantation have been in chronic phase. The survival results for accelerated phase of blast crisis in transplantation are identical now than they were when Don Thomas first started doing this in the 70s and 80s. So we've made huge inroads in chronic phase, nothing in accelerated phase of blast crisis at all. So don't wait too long. Thanks.
Okay, final case. Ruben.
I like that.
Alrighty, well, a little change of pace in terms of, Andy really asked me to address a little bit about what does really low-level JAK2 mutation positivity mean, and a bit around some of these more equivocal cases that you might have to manage. So I wanted to really start with a question. First, what do you consider a positive JAK2 mutation test when it's reported back to you? Is it allele burden of 0.1%? Does it have to be 10? CALR reported mutation, JAK2 exon 12? Are these all positive JAK2 mutation tests? All right, interesting. So clearly it depends a little bit on how broad you're throwing the umbrella. I think for many of us in the MPN world, we consider when we say that to be the JAK2 V617F mutation. And then we can look at the difference in the allele burden. The JAK2 exon 12 clearly is a mutated JAK2. It has a little bit of a different natural history, primarily in P. vera, primarily leading with risk of thrombosis. The calreticulin we typically would view as an additional driver mutation, but separate. Jerry, any thoughts at the Hutch? What's kind of a threshold as a guy who knows much about BCRA, but what do you view as being a positive JAK2?
Yeah, so someone who runs a molecular diagnostics lab, including JAK 615, allelic burden of 0.1% is pretty much beyond the reproducibility of the test. And so I would not call that very much. Now, 10% is interesting because that sounds like it's low, but when you do allelic burden, what you're looking at is the mutant versus the wild type. So that's basically 25% disease burden to get an allelic burden on the test of 10%. So that's significant, right?
Good. Now, as things have evolved, there are, let's say, 2 layers of mutations you have to think about with patients with MPNs. There are the 3 main suspects that are what we are calling the driver mutations. V617F, that was the first one that was discovered. That was the most prevalent. Almost all patients with P. vera are over 90%, a little over half with myelofibrosis, a little over half with ET. Then there was the MPL, fairly uncommon mutation, but relevant in ET and MF. Subsequently, calreticulin ended up being a good chunk of the remaining number of JAK2 negative, quote unquote, patients with ET or MF. Additionally, there were the JAK2 exon 12 mutations in patients with PV. All of these mutations have the interesting part that they are mutually exclusive. So when you have one, you typically don't have the others. And in individuals where they found more than one, they've actually found 2 different distinct clones, but really it's pretty uncommon. Separately, there are the additional somatic mutations, which are kind of those raft of other mutations that clearly overlap between all 3 of our talks. ASXL1, IDH1 and 2, DNMT3A, those are the additional somatic mutations. At the Mayo Medical Laboratory, I was picking the brain of our lead for the Mayo Medical Laboratory, and they do a fairly high volume of these. nationally. And they actually said in the lab they have a detection threshold of 0.06%. So they consider kind of low-level positive 0.05 to 0.1% when it gets reported out as allele burden. As they've looked serially at cases both within from the Mayo system, but also that are external cases, from 0.1 to 1%, they're low level, but they really seem to be the real deal when they have information that they can really correlate, whether it be marrow findings, blood findings, history, things of that nature. Now, it does not mean, so it's a real finding, but do they truly have the disease? They still may have, which we'll discuss in a moment, the issue of CHIP, which is really an incidental clone identified with aging. There was a separate study that was reported where they looked at almost 1,700 sequential JAK2 mutation testing, and they found 2.6% of which were quote-unquote low, and they found overall about 1 in 4 roughly had an MPN. Now, this clearly overlaps with a disease we haven't included in this session, but it's relevant in terms of these somatic mutations. And when one finds a mutation, including the JAK2 mutation, is there a myeloid disorder or is there not? And increasingly, there's been the identification of this kind of subclone, the myeloid equivalent of an MGUS, where you identify a clone which may or may not be clinically relevant, a myeloid clone of undetermined significance with some rate of progression. And these rates of mutations, just like an MGUS, just like other monoclonal, the B-cell populations, clearly do increase in time. So, this is really a theme in terms of hematopoiesis in the marrow, with the ability to develop clones in the different lineages. Now, where does JAK2 fit in that mix? How likely are you to find one of these, somewhat incidental clones of aging? Well, they have been identified with the JAK2, but it's not one of the common ones. The DNMT3A is probably by far the most common, and it is an interesting finding, just going back to Jessica's talk, where again we look at individuals that have DNMT3A who do better. Is it a relevant clone, or are you still finding people who really have no clone and they have CHIP in the mix? Tough to say. So the case itself, wanted to have one of these cases is really are very tough for folks to manage, and really wanted to get a sense both from the audience as well as Jerry and Jessica what they thought. So a 47-year-old female, abdominal pain and bloating, evaluated in the emergency department, hepatomegaly, elevated transaminases, hepatic vein thrombosis, classic Budd-Chiari syndrome. The spleen is 5 centimeters below the costal margin. The blood counts are essentially normal. Hemoglobin is 13.7, white count of 8.5, platelets of 333. The EPO level is in the normal range. The JAK2 mutation is tested and is 15% allele burden. Jessica, your thoughts? Does this person likely have an MPN?
So I think this patient has clinical stigmata of an MPN. She has a hepatic vein thrombosis. It's unusual for an otherwise 47-year-old woman to develop a thrombosis in that region. And she has 15% allele burden of JAK2 V617F.
Jerry, what do you think?
I would put my $20 on that she does, and you might say, well, if we give her time, that we'll certainly find out. But with these presenting things that she's coming in with, I suspect we just can't sit around and just watch her and just rub our hands together and just see what she manifests into. So I suspect she's going to have something, and we're going to need to treat her sooner than later.
And it's interesting because this really overlaps with kind of the range of how patients with myeloproliferative neoplasms can present. In particular, it's thought that these individuals, the actual process of the Budd-Chiari itself might suppress the blood counts. So again, you have an inflamed liver, and would the platelets have been higher without the Budd-Chiari? Could there have been certainly erythrocytosis before? There's a lot of scenarios where, again, they're really good counts for somebody that has, Budd-Chiari syndrome. The marrow did not meet any specific diagnostic criteria of MPN. However, it's hypercellular, increased megs with some clustering, scant reticulin fibrosis, and the karyotype of 46XX. Now, it turns out as we look at these cases, there are certain clinical scenarios that have a much higher representation of likely some form of MPN, the presence of the JAK2 mutation, but have atypical presentations. So particularly areas that you need to be mindful of in MPN when you see a thrombosis, sagittal vein thrombosis, splanchnic vein thrombosis, these sort of atypical areas have a much higher rate. People are doing work in terms of what is it about that vascular supply or circulation that might lead these to be more common. But in this study from France, they had 241 patients who were JAK2 mutated who had splanchnic vein thrombosis. Those that had a positive were found to have an MPD. They looked at red cell mass, and they were able to triage most of these individuals into P-Vera, ET, or myelofibrosis. Interestingly, those with splanchnic vein thrombosis that were JAK2 negative, they did a marrow. They still found another 10 that had an occult MPN. Then amongst those that were negative for the marrow, they did endogenous erythroid colony and still found another 14 that likely had an MPN. So it's a group that you have to be highly suspicious of, even if they have a normal blood counts. So final question that I'll pose to the group, tricky one. So this individual is JAK2 mutated, they have thrombosis, no elevation in your blood counts. How would you treat them? Aha, a consensus. So it's interesting that I'm particularly interested in that number 4 was actually the only one that there's actually a clinical trial that's gone on with the use of warfarin and then pegylated interferon. So indeed, with these individuals, there's really no consensus. But before I make a comment, Jessica, what do you think? How would you treat this patient?
So Ruben, this is when I would call you and ask what.
Yeah.
I think we all agree that the patient needs some form of anticoagulation regardless, like warfarin is our choice here because of the active clot. And I don't think at this moment related to symptoms that the patient requires ruxolitinib. I chose warfarin alone, but I'd have to spend some time thinking again about the role of the addition of aspirin if we think that it'll have enough antiplatelet activity and if that's needed.
Jerry, what do you think?
So I'm completely biased because I just got off the transplant service and I saw a patient very similar to this from overseas who was treated very conservatively for a number of years with just the idea of watching and waiting and seeing what her counts did. And basically what happened was her physiology and her systemic manifestation completely outran her blood counts. Mm-hmm. So by the time she got to transplant, she was basically on death's door because of liver problems and splenic problems and infections and everything. But her counts hadn't really budged much at all. I do not know if Rux will change progression as opposed to cause decreased manifestation of constitutional. I don't know if we would really prevent that progression, but I would be inclined to try something besides just watching her with warfarin alone. Where's the clinical trial option? It's got to be a clinical trial option.
It's truly a case where we still do not have a clear evidence how best to treat these individuals. But certainly there is the hypothesis that, again, this formed and then the setting of just straight anticoagulation is probably inadequate for really trying to prevent extension of the clot, and kind of that healing process. And again, I think you are correct in terms of how long we wait to intervene is relevant. In the MPN world, there probably is consensus about some degree of cytoreduction. It's less clear what is really the target, whether it is to lower counts to the lower limits of normal, because there's this pseudo-normalization of the counts in the setting of the thrombotic event. So the trial that we're reporting out at ASH is with pegylated interferon in this setting. It was really feasibility in terms of them tolerating it, safety, things of that nature, but shooting for the lower limits of normal. But I think certainly one could potentially make the case for that. Ruxolitinib is an interesting idea. Certainly, if anything, this probably mirrors polycythemia vera. And there, in the second-line studies in PVERA, ruxolitinib has helped to decrease the risk of thrombosis, potentially through decreasing inflammatory cytokines, other things. Yep. So there certainly might be a role, but it's an area of investigation, and kind of raise it because this is the real world of dealing with MPN patients, and they sometimes can be quite complex. Thank you.
Yes.